Good morning. I'm Dr. Patrick O'Gara from Brigham and Women's Hospital and Harvard Medical School, and it's a pleasure for me to join you in this wonderful 2020 New York Transcatheter Valve Forum. I want to thank the directors of the course for providing me with this terrific opportunity to speak with you today. I have been tasked with a discussion of valvular heart disease in the COVID era, the path forward. Here are my disclosures, which should not impact the substance of my talk. Well, let's start by recognizing some of the significant advances in valvular heart disease that have occurred over the course of the past 2 decades. These would include our improved understanding of the natural history of the disease through several studies, the arrival of multimodality imaging, and our reliance on both echocardiography as well as CT imaging for the bulk of our decision-making in patients with valvular heart disease, but also with important contributions from cardiac magnetic resonance imaging. Transcatheter technologies have continued to improve and are now made available to increasing numbers of patients. It's been nearly 2 decades since Dr. Cribier implanted the first TAVI prosthesis. And we should also, I think, pay tribute to our surgical colleagues who have developed increasingly durable and successful ways to repair natural valve tissue, both in the mitral and aortic position. We can rely on randomized clinical trials for evidence in areas in which we did not previously have it. And finally, we have made great strides in terms of understanding the presentation, management, and outcomes of patients with valvular heart disease through our registries, chiefly here in the United States through the STS-ACC-TVT registry. Here I'm showing you an example of the benefit of using multimodality imaging to gain a better understanding of the natural history of aortic stenosis. These are data from a cardiac MR study looking at both diffuse interstitial fibrosis and replacement fibrosis in patients with aortic stenosis exposed to chronic pressure overload. And not surprisingly, increasing degrees of myocardial fibrosis, as shown here on the right-hand side of the slide, are associated with reduced event-free survival over time. And certainly our ability to detect abnormalities in the ventricular adaptation to the chronic pressure overload has increased and improved dramatically over the course of the past 10 years. Think now of the application of global longitudinal strain imaging as a routine feature of the assessment of patients with aortic stenosis. And here are examples that we've learned from 4D CT to understand the incidence as well as the importance of hypoattenuating leaflet thickening, namely bioprosthetic leaflet thrombosis in patients who've undergone transcatheter aortic valve replacement. We now understand from several studies that this occurs in up to 10% of patients early on following valve implantation. But we also understand from recent data published from the Partner 3 registry that this is a very dynamic process. And as many as 50% of patients who have documented leaflet thrombosis at 30 days will not have leaflet thrombosis at 1 year, whereas as many as 20% of patients without leaflet thrombosis at 30 days may have it at 1 year. So these present challenges, I think, to the design, execution, and adjudication of trials of antithrombotic therapy following TAVR. Dr. Dangus will speak with you later in this course about that particular entity. Now, we certainly have had several advances in valvular heart disease understanding, but there remain substantial gaps. For example, the appropriate screening and detection of individuals in the community with valvular heart disease, understanding who they are and recognizing them before onset of symptoms or irreversible changes in ventricular architecture or function. Appropriate access to services by which valvular heart disease can not only be evaluated but also treated. This, of course, is a huge issue that underscores or reflects problems with disparities in access to care and outcomes here in the United States. The equitable provision of not only evaluative services, but also corrective services in patients with valvular heart disease. Why, for example, do restricted lines of referral that are dictated by insurance coverage prevent an individual from being able to access a reference surgeon or a top-flight interventionalist in his or her community? And can we not make access to these kinds of expert services at comprehensive valve centers more uniformly available, independent of issues regarding finance? We know relatively little about the genetic underpinnings of valvular heart disease, including the genetic underpinnings of bicuspid aortic valve. Patients with bicuspid aortic valve have a smattering of single nucleotide polymorphisms that have been identified, however, without a dominant mutation. And we know that there is familial transmission, but familial transmission appears to be incomplete, variable, and certainly an area in which more data and more understanding are required. And what about our efforts at preventing the continued chronic and long-term progression of valvular heart disease over time? Certainly, we have not identified any particular pathways that appear to be successful when it comes to stopping the process of the development of leaflet fibrosis, thickening, calcification, etc., as would otherwise exemplify the natural history of somebody with aortic stenosis. And then again, I should point out that although we do have randomized controlled trial data in some areas in valvular heart disease, we have very little randomized controlled trial data across the entire spectrum, and more studies of this nature are needed, provided they can be appropriately designed and executed. Here's an example of a randomized controlled trial published just last year after presentation at the American Heart Association. This is a surgical study of patients with very severe asymptomatic aortic stenosis, jet velocities in excess of 4.5 meters per second. Patients were randomized to early surgery versus a strategy of expectant observation or conservative care. And patients who were randomized to early surgery had a marked reduction in a cumulative outcome of operative mortality or death from cardiovascular causes. The average follow-up in this particular trial was about 4 to 5 years. Additionally, perioperative mortality rates across the 4 centers in South Korea that performed this particular trial was 0%. And whether the results of this trial can be generalizable over a larger number of centers with a broader population or spectrum of patients, as might occur here in the United States, remains to be seen. But nevertheless, a very important randomized trial in the valvular heart disease space. Certainly, there have been several randomized trials in the TAVR space, but aside from these 2 areas, very, very few. Now, certainly TAVI has dominated our discussions over the course of the past decade. I'm showing you this very compressed timeline in which TAVI now is applied across the entire surgical spectrum of risk and is now being applied in research to patients with asymptomatic severe aortic stenosis and to persons who have moderate aortic stenosis with LV systolic dysfunction. It is being applied in an observational registry-based way to patients with bicuspid aortic valve disease, but I will have a few comments to say about that later. There are some issues and some gaps with respect to TAVI. They are included here on the slide. There are questions about valve durability and the age threshold below which one would feel increasingly uncomfortable to implant a TAVI valve compared to a surgical valve. There is uncertainty around appropriate use of antithrombotic therapy, single antiplatelet therapy, double antiplatelet therapy, combination anticoagulant antiplatelet therapy, or monotherapy with an anticoagulant. And if an anticoagulant is chosen, a vitamin K antagonist versus a non-vitamin K antagonist. This space has evolved very quickly. There have been several trials reported and published over the course of just the past year, and Dr. Dangus will be discussing this further with you. There's the issue of conduction system trauma that occurs at time of TAVI, how to certainly predict its occurrence. but most importantly, the adverse long-term consequences of right ventricular pacing. The uncertainty as to who with bicuspid aortic valve disease may be a candidate for a TAVR intervention, although these patients were excluded from the randomized trials of TAVR versus SAVR. Certainly they are undergoing TAVR intervention with increasing frequency as each year passes. We must learn more about them, and hopefully we can eventually design a trial that would provide us with more transparent understanding of the comparative effectiveness of surgery versus transcatheter strategies for younger patients with bicuspid aortic valve disease. And then lastly, the very challenging issue, what is the appropriate strategy when anticipating that sequential procedures will be necessary over the lifespan in a younger individual who opts for a biologic heart valve replacement. These, I think, are difficult discussions that should be had prior to the index procedure itself. Now, I'd like to talk a little bit about the gap with respect to preclinical information that might impact our further understanding of valvular heart disease here, even in the COVID era. And we have spent most of our time, certainly over the course of the last decade, concentrating our efforts at interventions in patients here with severe disease of a symptomatic nature. And certainly TAVR has established itself as a transformative technology that has revolutionized our approach to valvular heart disease writ large. But can we not turn the clock back and focus efforts here at the earliest stage when identifying patients who are at risk for the development of valvular heart disease, such as persons who live in sub-Saharan Africa who have acquired a rheumatic fever at a young age, or individuals who are born with a bicuspid valve recognized in childhood and adolescence? Can we apply any kind of preventive measures so as to forestall or even abrogate the need for an intervention later in life? Now, certainly, we all know that the development of calcific aortic stenosis is an active process that typically evolves over the course of decades, and it depends in its earliest stages on endothelial dysfunction, on inflammation, on fibrosis, on calcification, on biologic processes with which we are quite aware. And we can actually follow this active biologic process with PET imaging, as shown here by Professor Dweck and colleagues when looking at the intensity of macrophage activity here at various early stages of disease that would go on then to predict increasing degrees of calcification over time. It's important to point out that these three atherosclerotic risk factors, namely hypertension, diabetes, and dyslipidemia, comprise a third of the population attributable risk for the development of new onset aortic stenosis across a population. Should not efforts at these three common atherosclerotic risk factors be doubled? And should we not see that if we could control these at a relatively earlier age, we would then show benefit not only with respect to a reduction in myocardial infarction and stroke, but also possibly with respect to a reduction in the incidence of a severe aortic stenosis over time. There's been great interest in the identification of lipoprotein A as a potential instigator, if not accelerant, of the process of aortic valve calcification over time. And we are excited about developments that have occurred with regard to the use of antisense oligonucleotides that are specifically targeted against lipoprotein A and shown to reduce their levels significantly. And now whether we can show a connection between a reduction in the level of lipoprotein A and a reduction in clinical events remains to be seen. But certainly there's great excitement in this particular area. There have also been some early observations with respect to clonal hematopoiesis of indeterminate potential, or CHIP. And as you know, this particular problem that resides among a certain clone of bone marrow cells can be responsible in late age for the development of a variety of chronic illnesses, including atherosclerosis. And these investigators in Europe have identified chip driver gene mutations that are associated with increased inflammatory activity that appear also to be associated with worse outcome following TAVI implantation in elderly patients with aortic stenosis. And I'm sure that we will learn more about the intersection between clonal hematopoiesis and of indeterminate potential, atherosclerosis, hypertension, diabetes, inflammation, and endothelial dysfunction as the years go on. Now, a few words about the COVID pandemic and in the era in which we find ourselves and the implications not only for access to care, but also for the research that we still need to do as a community in order to understand valvular heart disease at increasingly granular levels. First, we should start with the recognition, though, of the structural racism that unfortunately characterized or has characterized so much of our activities over the course of time. Certainly here in the United States, we have learned quite a bit about disparities in outcomes as a function of race, as a function of zip code, as a function of a variety of the social determinants of health. And certainly we have obligations as an individual, as an organization, and as health systems to actively and everywhere try to deconstruct the barriers that allow structural racism to be perpetuated from one week to the next. These, I think, would eventually impact a variety of attributes here, as you can see around this particular circle, that continue to contribute to the adverse health outcomes and adverse outcomes with respect to valvular heart disease that the unfortunate, that the underprivileged, and typically people of color experience here in the United States. Now, it's not lost on anyone that we are yet in the third surge of COVID infection here in the United States. These are data taken from November 24 publication, the COVID tracking project. And as you can see here, the daily case rate in the second panel here has increased sharply just over the course of the past 6 weeks. We know that states that did not apply public health restrictions to the same rigor as other states seem to unfortunately be experiencing increasing incidence of new infections as each day goes by. There's an increase in the number of hospitalizations and unfortunately an increase in the number of deaths. And certainly the pandemic dominates all of our lives, not only with respect to the work we do within the hospital, the decisions we make with regard to resources, the performance of elective procedures, our educational efforts, as well as our interactions with family and the broader community is completely dominated by COVID. And it's not clear that the end is clearly or rapidly in sight, I should say. We're hopeful for the vaccine, but time will tell. Now, it's interesting to go back in the early stage of the pandemic and remind ourselves of some of these startling observations that were made. Here I'm showing you hospitalizations across the Mass General and Brigham, beginning here in January and through the end of March, early April. And as is true in Boston in general, Massachusetts, as well as New York and New York City, there was a sharp reduction in hospitalizations during the second month of the pandemic. These are the so-called missing patients. And we all saw a marked reduction in patients with acute myocardial infarction, with acute stroke, and with congestive heart failure. Were they staying at home? Perhaps that was the case because on the other or the flip side of this particular observation was the observation that there was an increase in the number of calls to emergency medical services for either out-of-hospital cardiac arrest or the observation of death without the typical trappings of a cardiac arrest. More people were dying at home, possibly because of their active decisions not to seek medical care out of fear of infection. And this particular observation then could be rapidly applied to what was happening with respect to our ability to do clinical research. People were not coming back to the hospital. They were perhaps also acquiring infection and developing endpoints in clinical trials that would not otherwise have been predicted when the statistical analysis plan was initially designed. And here I'm showing you some data from clinicaltrials.gov that were published by Mario Guadino and colleagues in Jack earlier this year, showing, as you can see here, a spike of activity in April, representing the number of trials that were stopped during the early phase of the pandemic on the basis of the desire to protect research personnel, as well as the observation that fewer patients wish to return for follow-up visits to provide informed consent and all of the other challenges that occurred early on. And stopping clinical trials of this nature, of course, had and continues to have serious implications for the research ecosystem going forward. Here is a statement from the Heart Failure Collaboratory that was published in Jack earlier this year, showing the effects of COVID infection on the number of research sites that remained open. And you can see here this downward curve, a decrease in adverse event reporting, and a decrease in cardiovascular hospitalizations that I've already showed you. And on the flip side, of course, the increase in cardiac arrests. Well, almost immediately, efforts were put into place to try to overcome these barriers, ranging from first and foremost to protect the health and safety of not only our patients, but also our research assistants and our research enterprise. Other ways by which to ascertain endpoints using wearable devices, changes in event adjudication, also changes in the prospective statistical analysis plan, and difficult decisions about whether to suspend a trial, to terminate a trial, or to continue a trial in hopes of being able to capture more events towards the end of the trial. And also on the flip side, there are other things that occur that have changed our lives, I think, forever. Certainly the advent of telemedicine services is here to stay, and we will always go forward with a different attitude as well as a different reimbursement towards both telephone and video visits with our patients, so as to avoid the need for in-person evaluation in a hospital setting. The same is true, I think, of our educational classroom work as well as forums of this nature. It's very unlikely that we will go back to the kind of in-person meetings that we were using routinely in the years preceding this particular pandemic. There's been important deregulation, I think a very important look again at the judicious use of resources, and much more collaboration across clinical trial enterprises, certainly heart failure trialists and valvular heart disease trialists, to name just a few. The FDA, of course, does not sit idly by. They have stepped forward and made it easier for all of us to continue our clinical research efforts during this period of time. They have helped in reframing issues about how it is that informed consent should be obtained, whether this can be obtained electronically, whether this can be obtained remotely by other means, data collection, which can also be obtained now remotely using wearable devices, to which I previously referred, endpoint adjudication, event adjudication, flexible sample sizes, adaptive design with respect to trials, and then some modification of statistical analysis plans as dictated by the reality of being able to bring a clinical trial to completion. We should all pause, I think, and congratulate and learn from our colleagues in the UK who put together this simple trial. This simple trial among many simple trials that they designed and executed. This is the Recovery Collaborative Group, published in the New England Journal of Medicine, showing an improvement in survival in intubated patients with COVID-19 treated with dexamethasone compared with those treated with placebo. A very, very important observation that was enabled by the platform design nature of the trials that they had established. Remember also, they looked at hydroxychloroquine, among other interventions that did not turn out to be useful. They were able to enroll rapidly, possibly because they worked through the National Health Service, and they certainly relied on a very simplified case report form. And this became, I think, the template that has now been utilized by the NIH in the construction of the ACTIV-4 trials, looking at the use of anticoagulation for the prevention of thromboembolic complications in patients with COVID infection, including patients hospitalized as well as patients following hospitalization. So there are some barriers to a pragmatic study, and I'd like to end with this particular discussion of whether, for example, there would be enthusiasm for an evaluation of SAVR versus TAVR in patients with bicuspid disease. This is a very thoughtful piece that was published earlier this year by Adrian Hernandez and colleagues in the New England Journal of Medicine that points out the barriers to pragmatic trials when studying intervention A versus intervention B. There's a lack of incentives currently in this space. Of course, there's the label indication that allows the use of TAVR in patients with bicuspid disease. There's limited enthusiasm because perhaps the train has left the station and this is being done frequently enough that it's no longer interesting. Patients are resistant to randomization. The informed consent process, especially during the workflow, is onerous. And then, of course, the implications of COVID and the difficulty in performing research in the current environment. Nevertheless, I do think that these can be overcome. We have much to learn from the Recovery Trial Collaboratory. We have much to learn as well from the Sweetheart investigators who helped provide us with a template for the performance of a randomized trial in a registry-based format. And I do hope that we can continue with our efforts of activism as well as inquisitiveness as to maintain the equanimity necessary to always acknowledge that there's much more to be learned in this space of valvular heart disease. The structure and the substrate is there, and I think we as a community can move forward in a very positive way with much confidence. I do want to thank the organizers once again for allowing me to participate with you. I hope you enjoy the rest of the course. Thank you.